is syndrome of inappropriate antidiuretic hormone secretion. And in this condition, the amount of antidiuretic hormone is increased. And we will discuss about the etiological part as well. Why is that so? Why is the amount of antidiuretic hormone is increased? First of all, the SIADH is strongly associated with central nervous system infections. Okay, it is strongly associated with any sort of infection of the central nervous system because this infection leads to the resetting of osmostat. What is resetting of osmostat? It means that the release of antidiuretic hormone is under influence of certain threshold osmostat, right? It means that when there is resetting of osmostat, that release of threshold, the threshold for the release of the antidiuretic hormone is reduced. The threshold that is responsible for the secretion of antidiuretic hormone is reduced. It means that in past, when the person is not suffering from SIADH, there is a specific threshold on which the ADH starts to release from the posterior pituitary. But when the threshold is reduced and the patient is suffering from SIADH or certain CNS infection, it means that ADH can be released at a lower threshold than the normal. Other etiological part is that infections such as that cerebral toxoplasmosis. What is cerebral toxoplasmosis? It is a infection toxoplasmosis, right? It is caused by the organism known as Toxoplasma gondii. I'm not writing the name, but the worth mentioning part is that infection leads to SIADH. Cerebral toxoplasmosis, it is a opportunistic cerebral infection, and it's caused by the organism known as the Toxoplasma gondii. And this cerebral toxoplasmosis is positive in the patients with HIV and AIDS. Okay. Along with the cerebral toxoplasmosis, the patient or the person may have suffered from HIV or he have history of AIDS, right? It is worth mentioning part. The second is that as we have discussed CNS infections like cerebral toxoplasmosis, we also have to mention the meningitis and encephalitis. Meningitis and encephalitis, these are the inflammation of the meninges, encephalitis. And in the patients of meningitis and encephalitis, when we give the fluid therapy because these patients are already suffering from SIADH, so fluid therapy when administered is 2 by 3rd. It means that, for example, if the calculated amount is 100, so in the patients with meningitis and encephalitis, the nurses or the doctor should give that patient 2 by 3rd of the calculated amount because already the person is having SIADH and there is a lot of fluid accumulation inside the body. So fluid therapy must be kept in mind in the patients with meningitis and encephalitis. The other thing is that brain abscess can also contribute to the development of SIADH. Also, there can be ectopic production of SIADH. What is the ectopic source for the production of SIADH? Let me mention here. Ectopic source means that there is some other source in spite of the posterior pituitary that is the original source for the production of ADH. But in case of ectopic source, rather than the original source, some other source is contributing to the production of certain hormones. Ectopic source can be carcinoid syndrome. It can be carcinoid syndrome, or we can write in place of carcinoid syndrome, Kalchitsky cell tumor. Kalchitsky cell tumor. Let me correct the spellings here. It's Kulchitsky cell tumor. And what is Kulchitsky cell tumor? It is nothing but the enterochromaffin cells of the GIT. Kulchitsky cell tumors are mentioning to the enterochromaffin cells of the GIT. Okay. Carcinoid syndrome or Kulchitsky cell tumor, they can also contribute to the development of SIADH. The other tumor is the Oat cell tumor. What is Oat cell tumor? Oat cell tumor is known as small cell lung carcinoma, small cell lung carcinoma, or we can say cancer. It is also contributing to the development of SIADH mainly, and Oat cell tumor can also lead to Cushing syndrome. Apart from SIADH, Oat cell tumor can also lead to Cushing syndrome, right? And the last but not the least are the drugs. There are several drugs that can contribute to the development of SIADH. For example, they can be vincristine and vinblastine. What are vincristine and vinblastine? These are anti-neoplastic drugs. Blastine. These are anti-neoplastic or anti-cancer drugs. Okay. The other pair of drug is known as the chloropromazine. Okay, it's chloropromazine, and the second is the haloperidol. It's haloperidol. These pair of the drugs are used as the antipsychotic drugs. These two are first generation antipsychotic drugs, and vincristine and vinblastine are the antineoplastic drugs. And one other drug that is no longer used now is known as chloropropamide. It's chloropropamide, and this was anti-diabetic drug, and this was eradicated from the market because it was causing SIADH in several people, right? The last disease that may lead to SIADH is known as multiple sclerosis. We'll discuss multiple sclerosis in some other lecture, but the basic definition of multiple sclerosis is that in this it is an autoimmune condition in which the immune system starts to attack the brain and the spinal cord. And in this condition, when it attacks the brain, it may lead to the resetting of osmostat, and then the threshold for the release of ADH is reduced. Let's talk about the criteria for the diagnosing of the SIADH. What is criteria for diagnosing, right? Criteria for diagnosing of SIADH. First of all, we need to mention here that plasma osmolality. When a lot of fluid is in the plasma, it means that plasma is diluted and plasma osmolality is less than 275, because plasma is diluted milliosmoles per liter. Or we can say per kg as well. In place of liter, we can mention kg. Plasma osmolality is reduced because a lot of water is being reabsorbed from the collecting tubules from the distal part of the nephron due to the hypersecretion of ADH. And what about the urine osmolality? Urine osmolality is increased because of the hypersecretion of ADH. The urine become concentrated. There is no much amount of water that is present in the urine. The next criteria is that these patients develop, okay, it's clinical euvolemia. Euvolemia. I hope the spellings are correct. Nevertheless, what is euvolemia? Euvolemia is that the total body water is increased and the total body salt is normal. What does it mean? It means that the total body water of the patient is increased. It's logical because of the release of ADH. A large amount of water is being reabsorbed from the distal part of nephron but the total body salt is normal. That is the main thing we need to remember in case of euvolemia. Why is there euvolemia? Why is there no hypervolemia or hypovolemia? So the euvolemia can be manifested as no edema. There is no edema in the patient. There will be no orthostatic hypotension, no orthostatic static hypotension, okay, hypotension, and there is no ascites. Ascites is nothing but edema in the abdominal cavity. What does it mean? It means that in conditions of hypervolemia, we see edema and ascites, and in the condition of hypovolemia, we see orthostatic hypotension, hypovolemia. But there is no hypovolemia, neither hypovolemia nor hypervolemia. It's euvolemic condition. So there is no edema, no ascites, and no orthostatic hypotension. Let's talk about the other diagnostic criteria. That is the urinary sodium. Urinary sodium is increased, and this is one of the most important diagnostic criteria we need to remember in SIADH. Urinary sodium is increased more than 40 milliequivalents, right? Milliequivalents or millimoles per liter. It is very important to know that in case of SIADH, the urinary sodium concentration is increased, and why? The question arises that why there is hypernatriuresis. Okay, why there is hypernatriuresis. First of all, we know that in response to antidiuretic hormone, there is a large amount of volume inside the body. It means that it stretches over atria. Atria are stretched and you know that there is special type of hormone, or we can say a peptide, that is released when atria are stretched, known as atrial natriuretic peptide, or we can say atrial natriuretic factor. And what is the function of atrial natriuretic factor or peptide? Its function is natriuresis. Natriuresis. So our question is resolved that because of the stretching of the atria, there is release of atrial natriuretic factor or peptide. It will promote the sodium loss into the urine. And the other diagnostic criteria is that the thyroid function test, TFT, should be normal. Let me explain that in case of SIADH, the thyroid function test should be normal. Let me explain that in case of low thyroid hormones like low T3 or T4, that we call as hypothyroidism. We call the low amount of thyroid hormone as hypothyroidism. And when there is low T3 and T4, the regulation of the release of antidiuretic hormone is stopped because the thyroid hormones regulate the release of ADH. When there is low thyroid hormones, there will be low regulation, and when there is low regulation, it will cause automatically the release of antidiuretic hormone into the bloodstream. And when the antidiuretic hormone is released into the blood, it will cause euvolemia. Okay, it will cause euvolemia. But we have mentioned that in case of SIADH, there is also euvolemia. So how we gonna know that this euvolemia is due to the hypothyroidism or it's due to SIADH? It means that in the diagnostic criteria for the diagnosing of SIADH, we need to rule out the hypothyroidism. It means that thyroid function test should be normal. The next test that should be normal is the adrenal gland function. The adrenal gland function should also be normal in case of SIADH. Adrenal gland function should also be normal, right? And how to know that whether the adrenal gland is functioning properly or not? We can check the electrolyte balance. We can check electrolyte balance. And the second thing, we can check the blood pressure of a patient, and then we can know whether her or his adrenal glands are functioning properly or not. The next criteria, there are a lot of criterias I know. The next is the kidney function test. Kidney function test should also be normal. Okay, there should be no problems within the tubules. The tubule problems should not be there. The parenchyma problem should not be there, because the cause for the SIADH is not the kidneys, it is the ectopic production of ADH, or it can be the reduction of the threshold due to the resetting of osmostat. The kidney parenchyma or tubules are not the reason, right? The patient, in case of SIADH, while doing the test, should not be on diuretics, because diuretics can affect the results. So diuretics must not be used within 1 week of the test, right? And there should be no hypokalemia. Why is that so? Hypokalemia should also not be included in the diagnosing criteria, because there is no acid base imbalance. There is no acid base imbalance. What does it mean? No acid base imbalance. It means that the amount of aldosterone is normal. What is the function of antidiuretic hormone? Its function is to reabsorb water, right? Only and only water. What is the function of aldosterone? Aldosterone will reabsorb sodium along with the water. It will reabsorb sodium and it will reabsorb water along with the sodium. In case of SIADH, the only problem is ADH, it's not the aldosterone. So it means serum aldosterone is normal. Serum aldosterone is normal. It means that there is no hypokalemia, because aldosterone reabsorbs sodium and water and excrete potassium and hydrogen. When there is normal aldosterone, there is no involvement of aldosterone, so there will be no excretion of potassium and hydrogen, so there will be no hypokalemic metabolic alkalosis. No hypokalemic metabolic alkalosis in case of patients with SIADH, right? There is also supportive evidence we need to mention here, that in case of SIADA, there are several supportive evidence apart from these diagnostic criteria. Supportive evidence. What are included in this? First of all, it's the blood urea nitrogen. Blood urea nitrogen, then is the uric acid, and both of these amounts or quantities are lowered. Why is that so? Because there is antidiuretic hormone, it will cause dilution of the blood. So there is dilution of the blood. These all molecules will be in low amount. Blood urea nitrogen will be low. Uric acid in the blood will be low. There is a special type of test that we do in case of SIADH, that is known as the water loading test. What is water loading test? For example, if the doctors ask the patient to drink a large amount of water, right? The patient or the person will pass large amount of urine, right? But in case of the patients with the SIADH, when we offer the patient to drink a large amount of water, but due to increase in antidiuretic hormone, still the urine output will be low, water excretion will be low. And that water, that extra water that we have offered the patient, excretion, urine excretion will be still low. Right? Are you understanding? Because of the increase of ADH. So that extra water starts to build up inside the blood and it will cause hyponatremia. Hyponatremia, and it's dilutional hyponatremia. Because a large amount of water is present and the amount of sodium that is present in large amount of water is diluted, so hyponatremia will be there, and it can worsen the hyponatremia component, and the patient can develop seizures due to this fluid shift across the brain. He or she can develop cerebral edema. He or she can develop seizures due to fluid shift across the brain. What is the last but not the least, what is the treatment for such patients? First of all, we need to imply the rule of water restriction. Water restriction should be there in case of SIADH because already a huge amount of water is present inside the body of the patient, so water restriction should be there. And the second is the VAPTANS. What are VAPTANS? Like toll VAPTANS, what are VAPTANS? VAPTANs are inhibitors of V2 receptors. What are V2 receptors? V2 receptors are the binding sites of antidiuretic hormone, and the VAPTANs will inhibit these V2 receptors and they will cause, in spite the huge amount of ADH present inside the blood, the VAPTANs will still block the V2 receptor and it will not allow ADH to function. It's like reabsorption of water, right? So vaptans are important. One of the important vaptan is known as the toll vaptan. Toll vaptan is used to treat the hyponatremia in case of congestive heart failure, because in case of congestive or chronic heart failure there is hypervolemia. There is hypervolemia. Why hypervolemia in case of chronic heart failure? Because there will be low blood flow towards the kidney, low renal perfusion, it will cause RAS activation. Due to RAS activation, a large amount of aldosterone is released. It will cause reabsorption of sodium and water, but it will still leads to hypervolemia and hyponatremia. And this hyponatremia is again relative, right? Because of large amount of water present inside the bloodstream. This tolvaptan will block the V2 receptor. It will not allow the antidiuretic hormone to bind to it, and it can promote or it can cure the hyponatremia component. It will cause water loss. It will cause water loss and the hyponatremia component can be cured in this way. There is last graph like thing or table I must say that we need to draw. First of all is SIADH syndrome, right? And the second is the diabetes insipidus. The third is the polydipsia, that is psychogenic polydipsia, or I must write psychogenic as well. Psychogenic polydipsia. In the patients drink a large amount of water due to psychotic conditions. And the last is the adipsia, adipsic hypernatremia. Hypernatremia. We will see in these all four conditions the urine osmolality, the plasma osmolality, and the blood sodium levels, right? So first of all, we will see the urine osmolality. Urine osmolality. In case of syndrome of inappropriate antidiuretic hormone, a large amount of water has been reabsorbed from the renal tubules, so urine osmolality will starts to increase. Urine become concentrated. In case of diabetes insipidus, a large amount of water is released, is excreted, so urine become diluted. Urine osmolality will reduce. What about the plasma osmolality? Plasma osmolality, think logically. In case of SIADH, plasma become diluted, so plasma osmolality will reduce. In case of DI, the plasma become concentrated, so its osmolality will increase. And in case of psychogenic polydipsia, when a patient or a person is drinking a large amount of water, urine become diluted and the plasma become diluted, their both osmolality is going to decrease. What about adipsia conditions in which the person is not even drinking a single glass of water? Urine become concentrated and plasma become concentrated. I've mentioned that we also need to discuss about the blood sodium levels. Okay. What about in SIADH, the amount of sodium in the blood, sodium levels in the blood? Because the plasma is diluted, it means that sodium will also be decreased. It is relative hyponatremia. In case of diabetes insipidus, the plasma is concentrated, so sodium is also concentrated inside the plasma. In case of polydipsia, when there is low plasma osmolality, low urine osmolality, so amount of sodium will be reduced. There is again relative hyponatremia. And in adipsia, hypernatremia, the disease itself mentioned that there will be large amount of sodium inside the blood. This was for today. I hope you understand the concept regarding the SIADH, the clinical manifestations, the workup, investigation, and the treatment, the etiological part. And I will see you in the next video with some other disease of the kidneys. And this was for today. Thank you.